One in every two adults has been told it at some point. You need surgery. And here is what most of them are never told in that same appointment. Between 10 and 20% of all operations performed in the United States each year are completely unnecessary. For spinal surgery alone, more than half of lumbar procedures performed annually have been formally flagged as unjustified by independent review. That is not a small rounding error in the data. That is millions of people every year going under anesthesia, accumulating scar tissue that never goes away, spending weeks in recovery, and taking on real surgical risks for procedures their bodies never actually required. The system does not profit when you leave the clinic healthy. It profits when you are scheduled, sedated, and billed. That is not a conspiracy. That is a billing structure, and understanding it is the first step to protecting yourself. Today, I am going to walk you through 5 operations I would never perform on myself without exhausting every alternative first. Not because surgery is always wrong, but because in each of these 5 cases, the evidence is clear that a significant proportion of patients who undergo these procedures could have avoided the operating room entirely with the right conservative approach applied correctly and given enough time. I am Dr. Miguel Arens, specialist in preventative health and medicine. I am going to speak to you the way I speak to patients in my office, which is not the way a fee-for-service clinic has any financial reason to speak to you. Before we go any further, I want 2 things from you in the comments: your age and which of these 5 conditions you have been told you need surgery for. I read every comment personally, and your answers directly shape the follow-up videos I make. Let me start with the most important principle in surgery, the one that every experienced surgeon knows but almost never says aloud to the patient sitting across from them. The best operation is the one that was never performed. That is not cowardice. That is not a rejection of surgical skill. That is decades of evidence-based wisdom compressed into a single sentence. The moment a scalpel contacts your skin, something irreversible begins. Scar tissue, the dense, fibrous material your body lays down to seal any wound, does not dissolve. It does not remodel back to normal tissue. It persists, compresses neighboring structures, restricts circulation, and permanently alters the mechanical behavior of every surrounding structure. That is why the question every surgeon should ask before booking an operating room is the one that rarely gets asked at a 15-minute appointment. Have we truly exhausted every conservative option? Because once you are on that table, that question has no more answers. Here are the 5 operations I see performed most often without sufficient justification. Number 1. Spinal disc herniation surgery. You come in with low back pain, you get an MRI, the report reads herniation, and within days a surgeon is telling you that you need an operation. Here is what nobody says to you at that appointment. If you took 100 completely healthy people off the street, people with 0 back pain and 0 complaints, and put them in an MRI machine, roughly 50 of them would show a disc herniation or protrusion. Half the population, with no symptoms whatsoever, which means the image on the scan is not your diagnosis. The image is a finding. Whether that finding is the actual cause of your pain is an entirely separate clinical question, and it is a question that deserves a genuine answer before anyone schedules surgery. The spine is not a structure that benefits from passive rest and a scalpel. It is a dynamic, load-bearing mechanical system that responds to the right kind of movement. Specific, progressive rehabilitation targeting the deep stabilizers, the multifidus, the transverse abdominis, the muscles that actually support the intervertebral disc, can decompress a herniation naturally over time. Here is the biological mechanism behind that. The disc material that has herniated is composed largely of water-binding proteoglycans surrounded by a fibrous annulus. When that material is exposed to the correct loading environment, when the surrounding musculature is strengthened to reduce abnormal shear forces across the disc, the body begins a resorption process. The immune system actually recognizes the herniated nucleus material as foreign tissue and initiates absorption. Studies show that in the majority of cases, disc herniations resorb measurably over 12 months without surgical intervention. Research published in the New England Journal of Medicine following patients with lumbar disc herniations found that at 1 year, outcomes for patients who underwent surgery and patients who pursued conservative management were statistically equivalent. Both groups had similar pain levels and functional status. Surgery got some patients to that endpoint faster, but at 12 months, the gap was gone. My advice as a doctor: do not consent to disc surgery because of an imaging finding alone. Surgery is justified when you have progressive neurological deficits, worsening weakness in the leg, or loss of bladder or bowel function that have genuinely failed to respond to a full conservative rehabilitation program. Not 3 sessions of generic physical therapy. A real, structured, supervised program of specific spinal rehabilitation conducted over weeks with a clinician who understands lumbar biomechanics. If nobody has offered you that before offering you a surgical referral, you have not received adequate conservative care yet. Number 2. Hemorrhoid surgery. Hemorrhoids are one of the most common conditions in adults, and they are also one of the most frequently operated on without adequate investigation of what is actually causing them. Here is what hemorrhoids are mechanically. They are not a problem that starts in the anal canal. They are a downstream pressure problem. Hemorrhoidal tissue exists normally in every human body. What causes the symptomatic swelling, the bleeding, the prolapse is elevated venous pressure being transmitted downward into the pelvic floor. Where does that elevated pressure originate? In the majority of cases, it originates above, in the abdomen, in a process called visceroptosis, the gradual downward displacement of abdominal organs which compresses the major venous return vessels of the pelvis. This is anatomically identical to applying slow, sustained compression at the top of the thigh. Venous pressure builds in everything below that point. The thin-walled hemorrhoidal plexus is the most visible symptom of that pressure, but it is not the cause. When a surgeon performs hemorrhoid surgery without investigating whether organ descent is contributing to the elevated pelvic venous pressure, the procedure addresses the manifestation. The cause remains, and the tissue that was surgically removed is replaced by newly distended tissue driven by the same mechanical pressure that was never corrected. This is why so many patients who have hemorrhoid procedures find themselves back in the surgeon's office within a few years. A thorough mechanical evaluation before any surgical referral should include assessment of pelvic organ position, sacral mobility, coccygeal restriction, and intra-abdominal pressure dynamics. These are not exotic or unusual steps. They are fundamental diagnostic questions that should precede a surgical decision in every case. My advice as a doctor: before agreeing to hemorrhoid surgery, insist on a mechanical evaluation of your pelvic structures. Has anyone examined you for organ descent? Has sacral mobility been assessed? Has anyone addressed your bowel function, your dietary fiber intake, your straining mechanics? These upstream factors, corrected properly, can resolve hemorrhoids entirely without any procedure in many cases. Get those answers before you get on the table. Number 3. Diastasis recti repair surgery. Diastasis recti is a separation of the 2 vertical bellies of the rectus abdominis muscle at the midline. It is extremely common following pregnancy, and it is increasingly being offered surgical correction with alarming speed. Let me give you a real example of what this looks like in practice. A woman comes to see me. She has a diastasis of 7 centimeters, measured on imaging. She has been told by a surgeon that this is large enough to require repair. She is 38 years old, 8 months postpartum, and still breastfeeding. We start a supervised program of corrective core rehabilitation. Not crunches, which are contraindicated in diastasis because they load the rectus directly and worsen the separation. Specific deep stabilization work targeting the transverse abdominis and the pelvic floor. Progressive loading of the linea alba through appropriate intra-abdominal pressure management. Within several weeks, that separation of 7 centimeters is down to 3. Without anesthesia, without scar tissue, without 6 weeks of postoperative restrictions that would have prevented her from lifting her infant. The surgical indication disappeared with exercise. The physiology explains exactly why. Muscle is living tissue. It responds to mechanical loading. The connective tissue of the linea alba, the band that separates the two rectus bellies, is composed of collagen fibers that remodel in response to tension. The right loading pattern causes those fibers to reorganize, the separation to narrow, and the functional integrity of the abdominal wall to restore. What surgery does is mechanically approximate the edges, bring them physically closer together with sutures. But suturing closed a gap does not restore the neuromuscular connection between your nervous system and the muscle fiber. It does not rebuild the deep stabilization function. It does not correct the intra-abdominal pressure mechanics that allow the separation to develop in the first place. If those mechanics are not corrected, the same forces that created the diastasis can recreate it after the repair. My advice as a doctor: if anyone tells you your diastasis is large enough to require surgery, pause. Get a referral to a pelvic floor physiotherapist or a rehabilitation specialist with specific diastasis training. Follow the program honestly and consistently for 2 to 3 months. Measure the gap again. The result may be that the surgical conversation is simply off the table. Number 4. Venous surgery for varicose veins. This condition connects directly to what we discussed in hemorrhoids because the driving mechanism is identical: venous hypertension created by sustained pelvic compression from above. Picture the venous return system of your legs as a low-pressure network working against gravity. Blood climbs from your feet toward the heart, assisted by the calf muscle pump and maintained by a series of one-way valves inside the veins. These valves are delicate structures designed to function under low, controlled pressure. Now imagine that the organs of your abdomen have shifted downward under the influence of visceroptosis: the intestines, the uterus in women, the bladder. These structures press on the major venous vessels of the pelvis. The compression is slow, gradual. It develops over years, sometimes decades. But it acts like a tourniquet placed progressively tighter at the top of the thigh. Pressure below that compression point rises. The venous walls stretch. The valve leaflets begin to fail because they were not designed to manage the elevated pressure they are now facing. Blood pools in the superficial veins. The walls dilate. First, you see spider veins, the fine red and purple surface capillaries that are already a signal worth paying attention to. Then, over time, the ropey, bulging varices that are visible through the skin. Pregnancy and childbirth accelerate this process significantly. Prolonged standing accelerates it. Chronic straining from constipation adds chronic pressure from above. Vitamin D deficiency impairs vascular smooth muscle tone. Inadequate bioflavonoids, the plant compounds concentrated in citrus pith, dark berries, and leafy vegetables, reduce venous wall integrity over time. Modern vascular procedures, laser ablation, sclerotherapy, mechanical stripping, all produce visible results. The bulging disappears. The leg looks improved. But if the visceral apoptosis driving the pelvic venous compression has not been addressed, the same pressure gradient rebuilds new varices in adjacent vessels within 2 to 3 years. I have heard this from patients many times. I had it done twice, and it came back. That is not a technical failure of the surgery. That is a systemic failure to address the root cause. The procedure was applied to the symptom. The cause was left intact. The right approach starts with correcting the organ descent, restoring pelvic mechanics, addressing the nutritional contributors, and strengthening the supporting musculature. At early stages, spider veins, mild dilation, no skin changes, this conservative correction can stop progression entirely without any procedure. At later stages, where surgery is warranted and the patient wants the vascular work addressed, doing that work on a body where the underlying cause has been corrected means the surgical result holds. One well-timed procedure instead of a repeated cycle of procedures and recurrence. My advice as a doctor: if you are in the early stages, spider veins and mild dilation, do not rush to a procedure. Address the mechanical contributors first. If you stand long hours, modify that load. Address your bowel regularity to eliminate straining pressure. Support venous wall integrity nutritionally. Get your pelvic mechanics evaluated by someone who understands visceral position. Then, if surgery is needed, go into it having addressed the cause. Number 5. Surgical repair of pelvic organ prolapse. This is the most significant procedure of the 5, and it is one where timing is the critical variable in a way that is not true of the others. Pelvic organ prolapse is the downward displacement of the uterus, the posterior wall of the bladder, or the anterior wall of the rectum, progressively toward and eventually through the vaginal opening. It develops through a two-sided mechanical failure. From above, visceroptosis, the sustained downward pressure of abdominal organs. From below, a weakened pelvic floor, where the muscles of the perineum have been stretched, the ligaments that suspend the pelvic organs have lost tensile strength, and the structural support system of the pelvis has been progressively compromised. This is not an event. It does not happen suddenly. It is a years-long migration of structures downward as the forces holding them in position progressively fail. And that gradual nature is simultaneously the danger and the opportunity. The danger is this: people adapt to slow change. You adjust to what has shifted. You stop noticing the dragging sensation, the pressure, the altered bladder function, because it has moved slowly enough for your nervous system to normalize it. By the time symptoms feel significant, the structural shift may already be substantial. The opportunity is this: at early and moderate stages, this condition responds well to conservative intervention. Pelvic floor physiotherapy, progressive strengthening of the abdominal wall and perineal musculature, visceral manipulation to restore organ position. These are not experimental approaches. They are evidence-based treatments that at early stages can stop progression entirely and in many cases produce meaningful reversal. I want to tell you about a patient I saw some years ago. She came in with first-degree prolapse, meaning the organs had descended but had not yet reached the vaginal opening. We began work: visceral manipulation to reposition the organs, pelvic floor strengthening, anterior abdominal wall rehabilitation. Her symptoms improved substantially. She felt better. And then life took over. She stopped coming. She stopped doing the program at home. She came back 5 years later. The prolapse had advanced to the point where conservative management was no longer sufficient. We performed surgery. The outcome was good. But she had missed a window that, if she had maintained the program, would in all likelihood have kept her off the operating table entirely. I do not tell that story as criticism. I tell it because it is real and because it illustrates what a meaningful variable timing is in medicine. An early-stage prolapse, treated seriously with the right conservative program, is often a manageable mechanical problem. An advanced prolapse that was not taken seriously becomes a surgical case. The anatomy does not change. The stage at which you decide to act changes everything. My advice as a doctor: if your physician tells you there is early prolapse, that is not a moment to adopt a wait-and-see approach. That is the moment to act, aggressively and conservatively, immediately. Pelvic floor therapy and structural rehabilitation at stage 1 or 2 can keep you out of the operating room for life. Waiting until stage 3 takes that option away. Now let me bring all 5 together with the practical framework that applies to every one of them. In every case, the word that matters most is first. First, find the mechanical cause upstream of the symptom. Not the symptom itself, the cause. For disc herniation, is it a loading problem, a stability deficit, a postural compensation that has been loading one segment asymmetrically for years? For hemorrhoids and varicose veins, is there pelvic compression from organ descent driving the venous hypertension? For diastasis, is there a deep core coordination deficit that the separation is a consequence of? For prolapse, where has the support system failed and why? First, exhaust the conservative options with the same commitment and professionalism you would bring to a surgical recovery. That means a real rehabilitation program, conducted under the guidance of someone who understands the specific mechanics of your condition, followed honestly and consistently for long enough to see results. Not 2 sessions, not 4 weeks of partial compliance, a genuine program. First, correct the upstream drivers before any procedure, because a surgical result applied to a body where the cause is still active is a result with a timer on it. And then, if surgery is truly the only remaining path after all of that, go into it on a body that has been prepared, corrected mechanics, restored tissue quality, eliminated upstream drivers. Then the procedure is done once, correctly, and it holds. Here is something I want you to understand about how this applies specifically after the age of 50. The connective tissue changes that drive all five of these conditions, disc degeneration, venous wall weakening, ligament laxity, fascial thinning, accelerate measurably after 50. Estrogen decline in women after menopause is a direct biological contributor to pelvic floor weakening and increased herniation risk. In men, core muscle mass diminishes and lumbar loading mechanics shift in ways that increase disc and pelvic pressure. These are not theoretical risks, they are changes I observe in examination every week, and they mean that the window for conservative intervention is time-sensitive. The same rehabilitation program that produces significant results at 40 requires more time and more commitment at 65. That is not a reason to skip it. It is a reason to begin it sooner and take it more seriously than you might at a younger age. I want you to leave this video knowing one thing above all others: a surgical referral is not a diagnosis. It is one option offered within a system that has structural financial incentives to perform procedures. Your job as a patient is not to comply automatically. It is to ask the question that your surgeon, at a busy 15-minute appointment, has no billing code for answering. Have we truly, honestly, completely exhausted every conservative option? If the answer is genuinely yes, then surgery has earned its place in your care plan, and you can approach it with confidence. If the answer is anything less than that, you have not yet received the full standard of care you deserve. Your body is not a problem to be cut around. It is a mechanical system that, given the right conditions and the right support, has a remarkable capacity to resolve problems it was told only a scalpel could fix. If something in this video challenged an assumption you had been carrying, drop the word clarity in the comments below. I read every one personally. Share this with someone who has recently been handed a surgical referral, with a family member who was told they need back surgery, with anyone who deserves to hear the full picture before they sign a consent form. Subscribe to Dr. Miguel Arens for weekly evidence-based health information that your clinic appointment does not have time to give you. This video is for educational and informational purposes only and does not constitute medical advice or a recommendation against any specific procedure. Always consult your physician or a qualified healthcare specialist before making decisions regarding your health. Every case is individual, and some conditions do require surgical intervention. The information here is intended to inform the conversation, not replace it. One more thing before you go. I want to address something that comes up every time I speak about avoiding unnecessary surgery, because someone always raises it and it deserves a direct answer. Is conservative management always slower? Yes. In most of these conditions, a well-executed surgical procedure will produce visible results faster than a conservative rehabilitation program. That is true. The bulging vein disappears after sclerotherapy in a way that does not happen after 3 weeks of pelvic rehabilitation. The disc is decompressed surgically in a way that takes months to achieve through rehabilitation. I am not going to pretend otherwise. But faster is not the same as better, and faster is not the same as lasting. The question that matters is not how quickly does the symptom resolve. The question is, what is the state of my body 1 year after this intervention, 3 years after, 5 years after? Is the underlying mechanical cause still present and building toward the next episode, or has it been corrected so that the body is in a different structural position going forward? There is published research comparing long-term outcomes for surgical and conservative management of disc herniations that is worth understanding. At 4-year follow-up, the difference in pain scores and functional outcomes between surgically treated and conservatively treated patients becomes statistically negligible in the majority of cases. Surgery accelerates the resolution. It does not change the endpoint. That is a meaningful finding if you are living with significant pain that is genuinely affecting your function and quality of life. Surgery may be the right choice to reach that endpoint faster, but it is a very different finding from the one implied in a consultation where surgery is presented as the only path to a good outcome. There is also the question of what surgery does to the tissue it touches. Every surgical procedure creates scar tissue. That is not a complication. That is the normal biological response to any wound. Scar tissue is denser, less elastic, and less vascular than the original tissue it replaces. In a spinal surgery, scar tissue can form around the nerve root that was decompressed. This is called epidural fibrosis, and it is one of the recognized contributors to what is called failed back surgery syndrome, a condition affecting a significant minority of lumbar surgery patients who continue to experience pain after technically successful procedures. In hemorrhoid and varicose vein surgery, scar formation in the surrounding tissue changes the mechanical properties of the structures that remain. In diastasis repair, the approximated tissues heal with a fibrous union that is structurally different from the original collagen architecture. In prolapse repair, mesh or suture placement creates adhesions and altered mechanics that occasionally generate their own long-term complications. None of this means surgery should be avoided when it is genuinely indicated. But it does mean that every procedure has a biological cost. And that cost compounds over time in a body that still has the underlying mechanical drivers unaddressed. The body does not forget what was done to it. Build your case for conservative management with the same seriousness you would bring to any significant medical decision. Give it the time it requires. Get the right specialist. Not just any physiotherapist, but one who understands the specific mechanics of your condition. Follow the program with the consistency it demands. And if at the end of that process surgery is still needed, you will have the clearest possible answer. The decision will be made correctly, and the outcome will be better for the preparation that preceded it. That is the standard of care you deserve.